Similarly, ISHRAE now tells that you can even give a empirical treatment, and if the patient's symptoms improve, it automatically diagnoses endometriosis. So probably instead of saying laparoscopy is no longer diagnostic code, we can say laparoscopy is no longer the first line of diagnosis. So what is recommended? Can you hear still and can you see my slides?
Yes, sir.
Yes,
Okay.
yes, yes.
Yeah. So what is recommended now by ISHRAE is that simple symptom diary or an app or a questionnaire is good enough to diagnose endometriosis early. But then if you have deep-seated endometriosis, deep infiltrating endometriosis, a vaginal endoscopy is better, even though the diagnostic accuracy is little low. Ultrasound or MRI are good enough, but the negative results do not exclude the diagnosis of endometriosis. That's where comes the empirical treatment to diagnose endometriosis. But when all of the above fail to diagnose endometriosis, one can resort to laparoscopy, wherein we can see special features of powder burn marks, adhesions, and that's how prove the diagnosis of endometriosis. What about histopathological evidence? It is actually desirable, but negative histopathological evidence does not exclude endometriosis. ISHRAE is very certain that the biomarkers are definitely not recommended at this stage. For example, CA125, and there are a whole lot of new biomarkers coming up now, but they are all at the experimental stage. They are not required to diagnose endometriosis. As far as the follow-up with the psychiatric support in the diagnosis, there is no clear-cut evidence yet. So the two main problems in case of endometriosis are infertility and pain. As I clarified right in the beginning of my talk, today I am not at all going to talk about infertility because I am going to mainly concentrate on adolescent problems. They do not have infertility. And in infertility, the main treatment is that of surgical treatment. So that is another reason why I am not going to talk today, because my topic is very clearly mentioned, medical management, specifically adolescents. Now, when I say the management of pain, we need to understand a little bit about the causation of pain. The mechanism of pain are of three types in endometriosis. Number one is a nociceptive pain. This is in response to noxious stimulus. What is the noxious stimulus? It is an endometriotic fluid, that is the chocolate fluid itself. You have to remove that in order to relieve the pain. That's where probably some amount of surgery is required. If not, you should have a good drug that can at least reduce this noxious stimulus. Second mechanism is inflammatory pain. Endometriosis is now categorized as an inflammatory disease. Even though it has got all the characteristics, or rather most of the characteristics of a neoplasia, it is not a neoplasia. It is very clear. It is not a neoplasia. So inflammatory reason is another reason. Third one is neuropathic pain. Neuropathic pain may be due to damage or dysfunction of the neurons. So unless you tackle all the three, the patient will continue to have pain, and that's why she will continue to suffer. So that's why we have to take care of all this. I told you nociceptive pain, you have to remove that noxious stimulus by surgery. The standard care of any pain would be a surgery plus medicine. Let's see, does surgery relieve pain in endometriosis? Yes, it will remove the noxious stimulus, but surgical destruction or removal of endometriotic lesions, even though they significantly reduce the perception of clinical pain, there is incomplete relief of pain, proving that pain with endometriosis is not just nociceptive, but it involves other two mechanisms, that is inflammatory and neuropathic mechanisms. So unless you tackle these two, patient will continue to have problems. So surgery is not the final answer. What are the problems with surgery? There will be usually recurrence. We have seen when you remove the cyst, within 3 to 6 months, the cyst comes back. And when there's a recurrence, you have to repeat the surgery. And when you repeat the surgery, it will become a difficult surgery. Second and third surgery is going to be much more difficult. And when it becomes difficult, the complications will increase. And when the complications increase, you need an expert to tackle them. And all of them will increase the cost. So the practice committee of American Society for Reproductive Medicine has told clearly that endometriosis is a chronic disease that requires lifelong management. Even though we say endometriosis is gotten rid of when she attains menopause, sometimes they may have pain still. So that has to be tackled. The goal of maximizing medical treatment and avoiding repeated surgery. So that's where medical treatment is very, very important in endometriosis. Does it mean there are no problems with medical treatment at all? Yeah, not at all. There are problems with medical treatment as well. First of all, failure to respond or a poor response. This will lead to temporary relief and patient will seek more drugs. And these drugs will have side effects. There will be non-compliance because of side effects. Then we have to use more off-label drugs, which are not very specific to endometriosis, and all of them will cause a gain. So let us look at the role of prostaglandins. Unless we understand the role of each one of them, we don't know how to treat the problem. These are the mediators of inflammation. We all know that. And if endometriosis is an inflammatory problem, definitely you will see a lot of prostaglandins in cases of endometriosis. They directly activate the nerve endings to pains. So unless you tackle these prostaglandins, the patient will continue to suffer. They trigger the release of other analgesic mediators like histamine, serotonin, NGF, and prostanoids from other cells and afferent nerves, stimulating peripheral nerve sensitization. They also stimulate aromatase enzymes that favor the continuous formation of estradiol. See the beauty of it. Prostaglandins themselves are pain creators. On top of that, they will stimulate aromatase enzymes to produce estradiol. Now let us look at estradiol. Role of estradiol. We all know there is cyclooxygenase that is the main culprit in any pain. COX is the rate-limiting enzyme that catalyzes the initial step in the formation of prostaglandins from arachidonic acid. COX, especially 2, is induced by endometriosis and leads to higher level of prostaglandin. See, they are all like one perpetuating the other problem. The endometriosis itself will induce COX-2. And COX-2 is like an enzyme. It's in fact a rate-limiting enzyme that catalyzes the initial formation of prostaglandins. And prostaglandin, we just saw in the previous slide, is the mediator of the pain. And COX-2 is stimulated by estradiol. Now you can make out the connection between all three of them. COX-2 stimulates production of prostaglandin. Prostaglandin stimulates the production of estradiol. Estradiol stimulates the production of COX-2. A perfect, what I can say, vicious circle. The role of estrogen. Estrogen acting as a neuromodulator that selectively repulses the sympathetic axons while preserving sensory innervation. So now let us look at this. What I said, let us summarize. Prostaglandins stimulate aromatase enzyme. because of which there will be production of estradiol. Estradiol stimulates COX-2. Now, COX-2 is the enzyme required for the production of prostaglandin. See how good friends they are. One helps the other, and they keep helping each other. So you have to tackle COX-2. That's where we use COX-2 inhibitors. You have to tackle prostaglandins. That's why we use antiprostaglandins. You have to reduce estradiol. That's why we use progesterone. So wonderful, isn't it? It's very, very clear now. We have to tackle all the three in order to tackle endometriosis. So now my job is very easy. I can run through the slides. So the medical management of endometriosis mainly involves, the concept is that you have to suppress the estrogen. We have already understood. Estrogen is the one which stimulates the production of COX-2. COX-2 is the one which stimulates the production of prostaglandin. Prostaglandin in turn stimulates the production of estrogen. Somewhere we have to break the chain. You start with the suppression of estrogen, so the chain is broken. Then we also have to stop the retrograde spillage. This is one of the important theories of formation of endometriosis. So that has to be stopped. Again, it will be stopped by both of these two objectives are met by progesterone. We have to overcome the progesterone resistance as well. And we have to use anti-inflammatory agents. Prostaglandins are the cause of pain. So we have to use anti-inflammatory agents. We have to use aromatase inhibition so that estrogen is not produced in the first place. Antagonizing estrogen is one thing. Stopping the production of estrogen is another. Anti-angiogenic factors. Ultimately, whether it is estrogen or progesterone or COX, the flourishing of endometriosis is because of the new vascularization. In fact, even in the cancer treatment, anti-angiogenic factors are taking a big role. If you don't supply blood to these tissues at all, how can they flourish? So that's where anti-angiogenic factors have a big role now in the medical management of endometriosis. And finally, we saw in the early slides the cause of endometriosis. Immune modulation is one of the important causes. That's why we have to use immune modulators. So all of them are required in the management of endometriosis. So traditionally, medical management has included hormonal treatment plus or minus, usually plus non-hormonal treatment. So hormonal treatment will tackle estrogen. Non-hormonal treatment will tackle the COX as well as the prostaglandins. What is the hormonal treatment? It is aimed to suppress the lesions, best achieved by menstrual suppression because you are stopping the retrograde menstruation. The choice of medical therapy should be individualized, of course. The traditional concept has been either a pseudo-pregnancy regime, which means progesterone, because what we see during pregnancy is mainly progesterone. The second regimen is pseudo-menopausal regime. That means create a situation like menopause when endometriosis almost dies down. That means use of GnRH antagonist, and in the past danazol. That's why I have graded this out. ISHRE guidelines tell the studies on GnRH antagonist treatments support their use as an additional, that is second-line treatment option. See, GnRH agonists have been the mainstay of treatment, but recently the GnRH antagonists also have a role, maybe an additional role or a second-line therapy. Danazol is no longer included in the recommendations. That's why you can see in the previous slide, I had given the gray color to it. I had not given black color to it. Non-hormonal agents include NSAIDs, basically. and they are beneficial for pain relief and reduce the bleeding also when used concomitantly with contraceptive agents. Pentoxifylline is another anti-inflammatory immunomodulator, and it has shown some promise. Finally, gabapentin, that is anti-epileptic drug actually, alone or in combination with amitriptyline, which is an antidepressant for neuropathic pain. Please remember, I told you, all three have to be tackled. What are the three things to be tackled? Nociceptive pain, either by surgery or by a medical agent, the inflammatory pain, and the neurological pain. So for mild to moderate pain, what is that sound?
Others, please mute yourself.
Okay. So mild to moderate pain with no endometriomas, which does not require a surgical removal. NSAIDs, that is COX-2 inhibitors, and mefenamic acid, which is antiprostaglandin, is good enough, very good enough. Okay. You can use continuous COCs. Nowadays, we have all sorts of COCs, continuous COCs. Or you can use progestins such as medroxyprogesterone acetate, norethindrone, or the most famous Dynogest. So these three are the combination that is good enough for mild to moderate pain with no endometriomas. Dynogest, one slide definitely should be dedicated to this particular wonderful drug, 2 milligrams daily. It inhibits prostaglandin E2 production in aromatase enzymes. It also inhibits angiogenesis and vascular proliferation, which is very important to tackle endometriosis. It reduces endometriotic lesions without a surgery. This is one of the biggest advantages of Dynogest, and effectively alleviates the pain. So it does all that we wanted. You have been listening to me by talking about prostaglandin, estrogen, and COX. It does all the three. It inhibits prostaglandin production. It also inhibits aromatase. That's why no estrogen also. And when there is no estrogen, there is no question of COX. When there is no COX, there is no prostaglandin. So how wonderfully it helps all the three. In addition, it also inhibits angiogenesis and vascular proliferation. So thus tackling the endometriotic lesions as well as the pain. It improves indices of quality of life. I remember very well one patient was always telling me that I want to commit suicide because of the pain. But within 3 months of Dynogest, she was so cheerful. It improves the quality. It is safe and tolerable up to 65 weeks. Almost you can continuously use for a year or two. That is one of the things in endometriosis, because it's a chronic disease. The treatment goes over the years, sometimes 10 years, 20 years. Patients get fed up. And we are also doctors not sure whether we can use these drugs so continuously for a long time. So safety of Dynogest has been proven sometime. Even in one of the lectures, one of the Japanese professors told he has used it continuously for 5 years, 6 years, 65 weeks. Definitely it is safe. And high rates of patient compliance. Patients 2 milligrams per day, 1 tablet, not a big issue at all. Severe pain, again with no endometriomas, in addition to what we have given, we may have to consider GnRH analogs. Of course, with add-back therapy. That means when you give GnRH analogs, there will be menopausal type of side effects. So for that, you may have to give a little bit of estrogen add-back therapy. Women whose pain does not respond to the above definitely require laparoscopy. Now I talk about hormonal treatment with a systematic review of 40 RCTs. It can reduce the pain when given at diagnosis. Adverse effects are common, of course, especially with Danazol, which is no more given. GnRH unlocks menopausal symptoms, DMPA also menopausal symptoms. OCPs are less effective than GnRH, but less likely to reduce the BMD of the bones to cause postmenopausal symptoms. And they reduce the hormone treatment, they will reduce pain and other symptoms when given for 6 months after conservative surgery. So hormones are useful at diagnosis. Hormones are useful after surgery also up to 6 months. So there are alternate to progestins. If somebody is fed up of using progestins for a long time, we have ethinyl norgestrone. I have not used any one of these. Etonorgestrel implants and levonorgestrel intrauterine device. This definitely all of us know. Now you may ask me, how does levonorgestrel intrauterine device, that is Mirena, popularly known as, help? It helps in many ways. Number one, it reduces the menorrhagia in adolescents and younger ladies who are not bothered about infertility. When the menstruation is almost becoming negligent, there is no question of retrograde menstruation. That way, fresh implants won't happen. And the progesterone there locally acts and reduces the estrogen. And estrogen means there is less of COX. Less of COX means less of prostaglandin. That way, levonorgestrel helps. Now, you may ask me, can we use Mirena or levonorgestrel in an adolescent? Yes, it is recommended in adolescents as a contraceptive agent. Then why not to relieve the pain? You may again question whether the hymen is intact or not intact and just like that. See, when the menstruation is happening, definitely hymen cannot be intact. Hymen is not intact. So definitely levonorgestrel intrauterine device is an option even in adolescents, or if not, at least young ladies, even in unmarried ladies, because once you insert them, they will work for 5 years. They will act in so many ways. I will repeat again. They will first of all reduce menorrhagia. They will reduce the retrograde menstruation. They will antagonize the estrogen, which means there is no production of COX, which means there is discouragement to produce prostaglandins. So a problem is tackled in multi-pronged way by using simply levonorgestrel intrauterine device. This is definitely an option in the married ladies, definitely, and those who have got already 1 or 2 kids. Because you cannot use Dynogest, even though the Japanese professor said you can use for 6 years. Usually, I have not used more than 2 years continuously. And other progesterones also, you cannot use more than 1 year, 2 years. Whereas levonorgestrel intrauterine device is such a wonderful boon. It can be just inserted and you can just forget it for 5 years and remove it and reinsert it. It will work till she attains menopause, and after that she will be totally relieved. So I'm underlining this levonorgestrel intrauterine device. Now, aromatase inhibitors, they are reserved for women with severe refractory endometriosis related pain. How do they work? They will reduce the amount of estrogen. Often used in combination with progestins, the disadvantages include bone loss with prolonged use. Whenever you use anti-estrogens, they will definitely have bone loss problems. Mifepristone, which is an anti-progesterone, 104 papers over 11 years evaluated. Difficult to judge whether mifepristone is truly efficacious. I do not use this. ISHRAE guidelines say anti-progestins are no longer included in recommendations. So, as I said, I don't use this. What about angiogenic inhibitors? I told you, you need angiogenic or neoangiogenesis for flourishing of the endometriosis. That's why angiogenic inhibitors have been tried. Endometriotic implants grow in ectopic locations with new blood supply. So VEGF inhibitors such as dopamine agonists, cabergoline, which we always use in cases of IVF if there is OHSS. So this is a very popular drug now. It has got anti-angiogenic and anti-neurogenic properties. That's an added advantage, especially effective in deep infiltrating endometriomas. So you can use cabergoline 0.5 milligrams per week up to 3 to 6 weeks. And if it is helpful, you can use on a long-term basis as well. Endostatin, Anginex, these I don't have much of experience. What about immunomodulators? As I said, There is a genetic factor, there is a immunological factor, and all of them have to be tackled. Altered immune function plays a major role in genesis, so immunomodulators decrease the inflammatory response to the disease. Laxoribin, it stimulates NK cell activity. TNF alpha inhibitors, again, I don't have much experience in these. All these drugs help in early stages, not in established stages. Interferons. Association of immunosuppression and endometriosis has been recently established, hence interferons have come into vogue. Two shot regimes are used. Again, I have no personal experience in this. Endometrioma treatment for pain. If there is endometrioma, what to do? All the while I was talking about when there is no endometrioma. Now, if there is a big endometrioma, especially more than 5 to 8 centimeters, and patient has pain, what to do? Just using dinogens, progesterones, the antagonist or agonist is not going to help. Painkillers definitely do not reduce the endometriomas. In such cases, you may have to remove them surgically. Cystectomy is the best option. Drainage and coagulation is the second best option, especially if you are not worried about the infertility part of it. And only drainage is a last option, especially if there are dense adhesions. You cannot put a laparoscope, you cannot put anything. You have to simply drain it. Very, very rarely we use unilateral salpingo-oophorectomy, bilateral salpingo-oophorectomy, THBSO, TLHBSO in a lady with endometriosis. Obviously, it is not an option in adolescents. This is not at all an option in adolescents. It is not even an option in younger ladies who have just married and who want to have children. This is probably an option only after the age of probably 35, 40 years. So ISHRE guidelines say post-operative medical treatment may be beneficial towards pain management and support a recommendation to offer it in women not desiring immediate pregnancy. Deep endometriosis, expectant management for asymptomatic women. For urinary and bowel symptoms, medical therapy with hormonal suppression is appropriate. Surgery is indicated only for women with urethral or bowel obstruction. Otherwise, better to avoid surgery. Lesions of non-reproductive organs. Appropriate treatment of complication is necessary. Ovarian suppression can be added to limit the disease progression or treat pain. That means endometriosis elsewhere. Now, surgery for neuropathic pain. We used to have procedures called presacral neurectomy, that is interrupting the sympathetic innervation to the uterus at the level of superior hypogastric plexus, or resection of uterosacral ligaments, or even there was something called LUNA, laser uterosacral nerve ablation. They do not actually diminish the pain in other areas of the pelvis. What does recent ISHRE guidelines say? LUNA, presacral neurectomy, and anti-adhesion agents are no longer included in recommendation. So they are all out. Gabapentin is better than LUNA. So let me come to the conclusion. That is clinical component pain. As far as pain management, what is recommended is shared decision making, obviously, NSAIDs. And in the first line, you can use COCs, progesterones in different forms. As a second line, antagonists you can add. And for refractory pain, you can use aromatase inhibitors. What is definitely not recommended is preoperative hormones, and there is no evidence for non-medical treatment. However, non-medical treatment sometimes can be useful. I'm going to talk about that quickly. Surgical treatment, cystectomy or CO2 vaporization, similar recurrence rates. Excision is definitely better than ablation. Presacral neurectomy, only experts can do this, but it is of no use anymore. DIA removal, centers of experts only. TIH is better than subtotal or plus minus BSO under the age, but it is only for the elderly. Post-operative hormones definitely are good adjuncts. What is definitely not recommended is LUNA and drainage and coagulation of the cyst. There's no evidence about, again, non-medical treatment. Now, in next 5 minutes, I will talk about alternative therapy of pain. Definitely, I am not an expert in this, but what is recommended also should be told. Just because we are allopathic doctors, we cannot say others don't work at all. Sometimes a good counseling also helps. I think most of the quacks, most of the other alternative medicine, they work because of talking nicely to the patients. And unfortunately, we don't have much time to talk to patients nicely. So they have an advantage. What are they? Number one is Ayurveda. Number two is yoga, especially this particular asana that is called Supta Buddha Konasana. It can be done in the sleeping posture or it can be done in the sitting posture. Of course, this is another asana. Meditation, especially away from the hustle bustle of the tense world. Naturopathy, of course, nowadays anything and everything there is cure in naturopathy. That's what they say. Green tea in green cup. I'm obviously joking. I don't know how much value have to be given to green tea and things like that. Homeopathy, they have treatment for everything. So also endometriosis. Reiki, I wish I had that magical hand just to take care of the pain like that. Chinese herbal medicine, they are using for everything, including infertility, endometriosis, acupuncture. Can you see the face of the lady? She's so wonderfully sleeping. Acupressure, cupping, though it looks ghastly, but supposed to relieve the pain. Stone therapy and chiropractic therapy, massage, aromatherapy. Exercise definitely helps because that will scientifically release endorphins and that will relieve the pain. Tai Chi is again, and low glycemic index diet and dairy products, they are supposed to be very useful. And there are a whole lot of diets for endometriosis. There are so many books on the net. TENS therapy, when I was PG, all the physiotherapy, they used to use TENS therapy. This is very good for endometriosis even now. Transcutaneous electrical nerve stimulation, electric current through electrodes placed on the painful areas. Pain relief is often very quick in this. So I told you in the beginning of the talk that the standard care of pain is surgery plus medicine, but now we may have to redefine it as surgery plus medicine plus alternative medicine, rather integrated therapy. So it will go like this. First, you offer surgery and post-operative allopathic medicines. If that do not work, slowly switch over to Ayurveda and homeopathy and naturopathy. If that doesn't work, prescribe yoga, meditation, and aromatherapy. And then you have got some more things like Chinese herbs, low glycemic diet, and dairy products, and more things like Tai Chi, acupuncture, exercise. If they are not working, come back to our therapy and keep cycling this for 20-25 years. And hopefully, when they attain menopause, they'll be totally gotten rid of the problem. So I'll end the talk by saying pain is inevitable in endometriosis, but suffering is optional. A good psychotherapy, satsang, may also relieve the pain. You have to divert your mind. So the sum and substance is pain is due to three reasons. One is nociceptive pain, inflammatory pain, and neuropathic pain. We have to tackle all three. For nociceptive pain, cystectomy, adhesiolisis, and elderly patients, TH, BSO, LUNA, presacral neurectomy. Last two are questionable now as per ISHRE. They improve perception of clinical pain, but there is incomplete relief. That's why you may have to use repeat surgeries, but that is not recommended. Medical management involves anti-inflammatory, mainly NSAIDs, COX-2 inhibitors, and mefenamic acid, which is an antiprostaglandin. Hormonal therapy includes progestins, GnRH analogs, even antagonists. And to suppress the menstruation, you can even use levonorgestrel, IUCDs, and gabapentin alone or in combination with amitriptyline help neuropathic pain. Thank you very much for your patient listening. Sorry for the interruption in between.
Thank you very much, sir. I am sorry for all the interruption that happened in between. It was a very wonderful, useful, and important talk, sir. I request all the participants, anyone who wants to ask question can unmute themselves and ask question directly to sir.
Sir, I want to ask one question. Is there any relationship between vitamin D deficiency and endometriosis?
Okay, vitamin D is now implicated in every single problem. Anyway, there is nothing like hypervitamin D problem, so you can give vitamin D, but proving that deficiency itself is very expensive, and giving that, instead of that we can simply give vitamin D. But as such, there is no direct relationship, but most of the problems are somehow connected to vitamin D deficiency. I think the time is up for everybody for dinner, 8 o'clock already.
Neha, any questions in the chat?
Ma'am, in the chat box is all full of compliments. Dr. Dolly Mehra says, excellent presentation as always. Dr. Rajkumari Purohit ma'am says, very well explained, sir. SDJ says, informative talk. Thank you all. Dr. Nilima Solankar is saying, excellent presentation as always, sir. Rupali Kokadwar is saying, very informative, sir. Surekha Handral says, so crystal clear. Dr. Seher says, sir, any relationship between menstrual cup and
Yeah,
endometriosis?
menstrual cup is now very popular among young girls instead of using the pads. I don't think it will have a relationship, because it's not going to encourage retrograde spillage, because they must be replacing the cups very frequently. As long as they do that, there should not be any problem. Unless I don't know whether mechanically if the cup is full and it will go backwards and all those things. But I have not found out in any literature that menstrual cup and endometriosis.
So Dr. Sonu Batham wants to know how to use DMPA in endometriosis.
Yeah, so DMPA, we use depot once in 3 months. See, these are all like, mix and match kind of things. For, let's say, 2 years, you give OC pills, patient gets fed up of taking pills every day. Then you switch over to DMPA, once in 3 months injections you give. Then she will have, menopausal type of problems, bone marrow density will come down. So you stop it after some 6 injections, switch over to Dynagest, stop it after 1 year, switch over to IUCD, that is LNG IUS, then that will help for 5 years. So it is something like dodging the ball in football. You don't allow to make the goal. You keep dodging this pain for 10 to 15 years somehow by keep on changing the different drugs and things like that. And hope that once she attains menopause, she will be totally relieved of endometriosis. There is no other way, because even surgery is not going to totally take care of the situation. Surgery is useful only in infertile patients, where you have to remove the big endometrium. There also, the role of surgery has become very minimal. That is, unless the endometriomas are so big and they come in the way of oocytes aspiration or growth, you don't even have to bother. You straight away start treating infertility with IVF and other things. And that means essentially the management now is medical management.
Sir, one question is directly posted to me. What should be the drug of choice in adolescent endometriotic pain?
Yeah, see, for pain, you straight away start with mefenamic acid, which is the simplest drug, antiprostaglandin. And then you can even add COX-2 inhibitors, because adolescent girls are little bit wary about taking hormonal treatment. So painkillers only should be able to manage that too at the time of periods if they have. If the painkillers are not doing their job, then you can start with a short course of Dynagest, which is very, very safe, which has got multiple ways of tackling the problem, including tackling the COX and the prostaglandins. 6 months of Dynagest, if it improves them, then they can continue it for years. And if they are not happy with that, you can give a continuous oral contraceptives to them also, because that nowadays most of the adolescent girls are now known by the medical education that is going around. They will accept it. So you can give them low, low estrogen type of hormones are available now. That can be continuously taken for 84 days or even sometimes 1 or 2 days and other things. And if they have no objection for LNG IUS, this is after trying the NSAIDs first, after trying the mefenamic acid and everything. You can consider inserting the IUCDs, but most of the mothers may not accept it. Before marriage, nobody would like to get a Clark inserted in them. So I think we can tackle their problem basically by analgesics initially and then add, if at all, Dynagest.
Sir, is there a need to give calcium supplementation when we give Dynagest?
See, actually, when you give Dynagest, it does not really have that much problem as GnRH analogs with respect to bone mineral density. However, calcium should be anyway given to all adolescent girls because the maximum calcium deposition happens by the age of 25. After that, only bone resorption occurs. So the best thing we can do, whether they have endometriosis or not, is to build up their calcium deposits before the age of 25, either by giving supplements or in the form of food. But there is no need to give a calcium just because you are giving Dynagest, to answer your question.
Sir, any prophylactic measures to be taken if endometriotic powder burns seen during cesarean section?
I don't think so. Maybe you can cauterize them. Cesarean section means you are lifting the uterus and you have to see the uterus and all that. I don't know whether anybody does that as a routine. No, because it is always behind such a big uterus, you have to lift the uterus and see. But if you see, maybe you can cauterize them, no harm. I'm just thinking right now as you're asking.
So what should be counseling for adolescent endometriosis, as we aren't very sure of the diagnosis, since we avoid invasive methods to confirm diagnosis?
As far as adolescence is concerned, whether it is endometriosis or PCO, the first and foremost thing in a counseling is that not to scare them. They get scared, and these days all adolescents are so tech savvy, they themselves go on to Google and get all sorts of wrong information, because sometimes it is mentioned PCOS patients can have endometrial cancer, endometriosis patients can have endometrial cancer or even ovarian cancer. They read these things first and then they get scared. So all that we can tell them is that this is a small aberration that is there, in which can be tackled. And the main problem in this is pain rather than anything else. And that pain can be easily tackled by simple painkillers. And one thing is that these ladies, if you are sure that they are having endometriosis, they should not postpone the marriage and becoming pregnant. That is the main issue rather than the endometriosis per se. So the counseling should go towards that end.
Right, sir. Sir, is danazol pessary available and is it worth?
No, as you saw in one of my slides, ISHRE clearly says danazol is no. Especially in adolescents, better not to give, because that will definitely cause postmenopausal symptoms in the young ladies, young girls, and it will also affect the bone mineral density. Whether it is in the form of tablet, pessary, it is a no now.
Thank you, sir, for such a nice elaborative deliberation on difficult topic of endometriosis. I also thank all the delegates who have joined us. Any more questions?
Thank all of you. Thank you once again for calling me.
Thank you, sir. Good night, everyone.
Good night.